Audio recording for this meeting has begun.
Well, hello everyone. This is Brenda with the Wyoming Primary Care Association. We're so glad to have you join us this afternoon for this great informational webinar on diabetes. You're going to find the information incredibly valuable. Before we get started, just a couple of housekeeping items. We are recording the webinar. You probably heard that we will post the webinar and the slides on our website. It takes us about 5 to 7 days to facilitate that. So if there's someone in your organization or you want to look at information again, it will be there available for you. Also, at the conclusion of today's webinar, we'll do an evaluation, and it's very important to us that we get feedback on how this information, if this information was important to you, if it was informational, all those different aspects. So be sure if you get a chance to do the evaluation for us. We hope to have time. Our presenter has just a wealth of information, and if we run short, you can put your questions in the chat box, and we'll capture those and get back to you if we don't have time to answer them today, but I think we will. Also, this presentation is CE eligible, and I'm going to let Diane go into that more about how you're able to access that if that's something that you have an interest in. So I want to go ahead and move us forward, and our presenter today is Diane True. And she is a registered nurse. She has a lot of experience. She's been doing this for about 35 years. She has a master's degree in business and program planning. She is also a certified diabetes and health educator. She follows the American Association of Diabetes Educators curriculum. She's also an adjunct professor for the School of Nursing at the University of Wyoming. And she's the site coordinator for the Diabetes Center in Cody. And without further ado, I'm going to let Diane go ahead and take it.
Hi. For those of you who do want to consider getting Category 1 CMEs, which we have Category 1 CMEs for nursing, which would include our nurse practitioners, any dietitian partners, and we have Category 1 CMEs through the Board of Pharmacy, and those are national level accreditations. So if you are a mid-level or a physician and require CMEs related to medications, I think we put my email at the end, but it's Diane, D-I-A-N, .true, T-R-U-E, @gmail.com. I have a little more paperwork for you, and then we would send your certificate right out. So we'll just do that up front. It's my pleasure to be here today. I do have not only our diabetes medications on this slide deck, but we also have a reminder for the hypertension since we share that population of patients. So we will concentrate today on the medications for diabetes. If we don't have time, those additional resources are at the end of that deck, along with the websites for those information. So I think we'll get started because I know everybody's time is very, very valuable. The accreditation information is up front, and so that's just the disclaimers for our CMEs. And we are able to provide this service through the Department of Health through a very gracious grant from the Center for Disease Control. So today's information is provided at no cost. We will follow the evidence-based research, and those are the sites that we will cite in these presentation and slides. I know that most of us understand that medications are merely an option. And as we move forward into 2018 and diabetes prevention becomes critical and actually will be a reimbursable element to our health education and our physician and client education, it was a very good tool for us to remind ourselves that lifestyle interventions are actually the #1 component for any of the care that we might do. And so as a quick reminder, we are reminded that nutrition counseling is one of the new clinical recommendations for diabetes as well as hypertension, and that newly diagnosed individuals and clients or patients we are putting on new medications for diabetes and hypertension, sending them to a dietitian is in the new scope of practice and in the new clinical guidelines. as well as we all try to motivate our patients to get that 150 minutes a week of even moderate or even chair-based exercise. That for diabetes, sleep is actually an independent risk factor for diabetes is an independent risk factor for obstructive sleep apnea. So many of our patients who have uncontrolled diabetes, uncontrolled hypertension, maybe they have a new arrhythmia such as atrial fib, should be screened for sleep. That many of our folks are already struggling. And so some sort of behavioral support, whether it's through official counseling or even community support, is an integral part of their care. And of course, we've strived for many, many years and have many, many resources for them to stop smoking to improve their health. So a quick review. Most of the new medications are designed in one or four components now, either to work directly on the beta cells, which help us to produce, store, or release insulin, or they work on the alpha cells in the pancreas to help you secrete glucagon, so that they help the new medications actually have a mechanism in their control factor to prevent or to mediate the low blood sugars. And so they turn off when everything is stable. Many of our new medications work on the incretin hormones, which are found naturally occurring in our intestinal system. And so they're designed with a different format to help you digest food more completely so that you have better pre and post-prandial blood sugars. And we're also going to talk about one of the new classes of medicines that will be added to this group, which are those that now filter through the kidneys. So for those folks who have impaired liver function or high cholesterol levels or have other metabolic issues that medications filtering through the liver system is not to their benefit, for the first time we actually have some new options. And we're going to talk about them in detail. I think it's important to just take a moment to think about how the new medicines work so that as we talk about them, they make sense. Given that, the American Endocrinology Group, along with the Internal Medicine Group, has given us some new guidelines and algorithms to think about how we add medications. And this slide, particular slide, kind of walks us through how to look at how patients present. Where is their A1C when they present? And some new thoughts and philosophies that will come up as we go on about how to add medications. And there are good reasons that this algorithm has changed, which we will talk about. This is a great slide to perhaps print and maybe even plasticoat as you and your partners think about how we add medications, not just about the cost, but how do they work and what medicines may give someone better efficacy as we move forward. And cost is a factor for sure. So our good favorites are, of course, metformin. It has been around for 40-some years. It actually works in two phases. First, it helps you to decrease the amount of glucose that the liver continues to leak, especially overnight. It helps to improve the way that insulin works in your muscles, and it actually reduces insulin resistance. And many of us have seen huge benefits from even moderate doses once or twice a day of metformin. Yes, it can have nausea. Yes, it can cause diarrhea. And some folks do not tolerate it well. But if they can get past that first 1 to 2 weeks as we slowly increase dosings, it has great benefit. And it is one of the anchors for many of our medication regimes. It is weight neutral. It has one of those medicines that has low risk of hypoglycemia, meaning that as you achieve a closer to normal blood sugar, 100, 120 even, it just stays there until it senses extra glucose. One of the key elements through long-time research is that if you're on this medication for long periods of time, as we know many people are on it for years, we do begin to see some malabsorption of B12. So if somebody's more fatigued, if somebody's having more issues, checking their B12 level and making sure that the malabsorption syndrome isn't happening is important. And we know, unfortunately, that this medicine has to be discontinued or the dosing drastically reduced when there is renal impairment. And depending on every hospital's policies, that we stop this medication prior to any radiology study that requires dye, so the CT scan or the MRI. And every hospital or radiology center has their own policy, but generally it's the night before and then for 48 to 72 hours after. So sometimes we have to look at bridging alternatives. The incretins, which are the injectable versions of your gut hormones, have been moved for third or fourth down the add-on list to second. And it has happened because of the long-term studies, now almost 8 years, that these medications not only improve blood sugars, but many people will lose weight on them as a secondary effect because they talk to your dopamine receptors and tell you that you're not as hungry, but that they help the body to produce better quality natural insulin. And they decrease the amount of glucose that the liver wishes to continue to excrete in spite of eating. And so they were moved up because they actually have also shown through the big clinical studies where you can measure C-peptides on a regular basis to actually improve and stabilize and reduce beta cell function loss. So folks who have been on these long term, their beta cell functions may be minimal. You know, you may have already lost 50 or 75% of your beta cell function when you develop your diabetes, but they keep patients from losing more beta cell function and perhaps will delay the amount of insulin somebody may need or even the potential for needing to go on insulin in the future. They are at low risk of hypoglycemia because, again, they've been designed to stabilize when blood sugars reach a near normal level. Yes, the disadvantage is that they are costly. If someone has Medicare or Medicaid or commercial insurance, they all have cards that make them very affordable. But many people on just a small dose of metformin and adding a GLP-1 may perhaps benefit over time, even though they're costly, to not needing as many other medications. Yes, they are injectable, but they use tiny, small needles that are the same needles in most cases that the new insulin pens use. And from many years of experience, once you get someone past the thought of giving an injection, they are very easy because some of them are once a day, some of them are once a week. If we don't have to use Bydureon, which is twice a day, unless an insurance company tells us we have to start there, we find that patients are more compliant, which I hate to use that word, but they are more compliant, and they benefit because they feel better. The nausea that patients experience is much like metformin. If someone can get past it, we find that for the first time in many years, patients have lost a few pounds. Their blood sugars over 4 to 6 weeks begin to improve. And for many folks, and especially ladies, when you can lose even a pound or two, even if it's over 2 to 6 months, they are much more encouraged to do other kinds of lifestyle activities. And personally and anecdotally, if we start patients on these medicines, we send them to the dietitian so they have a new meal plan. Yes, they have always had a black box warning for thyroid cancer, and we hope that it continues that only the rats got it because we don't have the same T cell function. And yes, there is a risk for pancreatitis because these medications slow down the digestive system, which is part of what makes them digest food more completely. And once in a while, you will unmask gallbladder disease. Medicines have to be stopped. You take and treat the gallbladder disease, and after someone is recovered and eating well, generally they can be restarted again at the smaller dosings and then increased as tolerated. And yes, I have seen some pancreatitis from these medicines, but in the hundreds of doses or hundreds of patients that I have personally had experience with, I think I've seen 2 cases in maybe 6 to 10 years. And the facility that I originally worked for, and I just retired, guys, I've only seen 2 cases. So it has not been an overwhelming burden. As a result, even the SGL, and there's a typo on this, and we have looked at this slide 10,000 times. It should read SGLT, so we were a little dyslexic. The L and the G are in the wrong place. So as a result, the SGLT2s or the sugar limiting transport mechanism medications that now go through the bladder and the kidney cycles have actually been moved up right behind the incretins. They are oral, which is usually easy to get people to take. And once in a while, we'll turn the GLP-1s and this one around because people are resistant to injections. But these help the body to stop the reabsorption that our kidneys love to do of glucose. And as a result, we aren't constantly reabsorbing that glucose that can sit in our bladder for 4 or 5 hours. Because they block the reabsorption, when people do urinate, they lose more water. And so they will lose more weight. So some folks actually who are on large doses of medications for their blood pressure and even small doses or larger doses of diuretics will actually get to reduce or stop their diuretics because you do lose an extra several hundred milligrams of fluid every time you urinate. So in most cases, there's a positive reduction in weight. There's a positive reduction in systolic pressure. There are even dosing options for renal impaired patients. So that gives us, again, many more options for some of our folks who can't or who can no longer take metformin. And you do have to pick your patients wisely, as we do with all of our other medications, because the patient who can't wipe themselves well is more at risk for a urinary tract infection. Ladies are more at risk for UTIs and yeast infections. The patient who isn't paying attention to doing some testing on their blood sugar may have low blood sugars with this medication because it doesn't have some of the other safety features in it that sense low blood sugar. Patients can get dehydrated. We have to remind them they still have to drink. And in some cases, they actually get a little more fluid because they are losing fluids. So we caution folks if they feel dizzy or fainting when they jump up out of their chair that they need to come and see us immediately so that we can reduce other kinds of medications that may lead to that. And if they become dehydrated, they could get hyperkalemic. So patients who have been on diuretics with potassium, we need to monitor those levels very closely. It generally calms down in the first 3 to 6 months. But our folks who, for the first time in many, many years, have positive blood sugars, some weight loss, some of our gentlemen who have and ladies who have their DOT at risk of having to go on insulin, we have given them a new life to have some options for medication. And Jardiance, which is one of the newer SGLT2s, just passed its very intense cardiac endpoint studies, and they were actually shown to reduce the incidence of MIs because of the controlled blood sugars. So if you've got our comorbidity level patients who frequently have hypertension and cardiac disease along with their diabetes, Jardiance may be an option. And while they're slightly more expensive, of course, the benefits of maybe only having to take a metformin and a Jardiance for extremely good, not only cardiac benefit, but blood glucose benefits and blood pressure benefits may outweigh the risk of a $200 a month medication. And they all have patient assistance, and they are all now covered minimally at Tier 2, even through the VA, which we just looked at. So finally, some options for those who have struggled over the last few years. So as a result, the oral DPP-4s, which are the other incretin hormone, have actually slid down the preference list. And that's, of course, Januvia and Onglyza and Tradjenta. And they've done that because they haven't proved as efficacious as we thought they were in the beginning, and they are still expensive. Yes, there are advantages to being taken once or twice a day with or without meals. Yes, it does help that gastric emptying, which means that you get better postprandial glucoses, but they have seemed to cause more concern as it's related to pancreatitis. They have not had the same weight neutral properties, but they did build into them the ability to sense and have that low glycemic and low blood glucose sensing. And so they're pretty neutral when your blood sugars are stable. And there are dosing options for the renally impaired patient. Anybody have any questions? Because this is just a lot before we move to the next pieces.
Diane, this is Brenda. You actually do have a question in the chat feature. Can you see it?
Chat. How much decrease in A1C would we see with these? Everybody is different, but it's generally 1 to 1.5%. And so if you take somebody from an 8 to a 7, that's a huge improvement. And, when we're striving for A1Cs of 7 or less in most patients, because remember, it's age and risk appropriate, we certainly don't want the rancher that's out there calving in February to have low blood sugars and lay in the field. You have to look that is a tremendous improvement. Everybody's different. I've seen more improvement, and it's over time. So if you get somebody 3 to 6 to 12 months out on these medicines, you see best benefit. But usually it's 3 to 6 months is when we see someone begin to level off, and that's their best improvement. A lot of people are started on oral medications, and at 3 6 weeks, if they haven't seen terrific improvement, they want to abandon them. We have to remember that red blood cells live for 90 to 120 days, and whatever coating of glucose they carry it for that whole time. And so until some of the old red blood cells have died off and the new ones are not receiving that same, glycemic coating, we don't see best benefit. So it's really somewhere in that 4 to 6 months range for most of the medications that we see best benefit. Metformin's probably the exception to that, but usually we see best improvement in 4 to 6 weeks. If that answers the question. And yes, there was a typo. We caught it the other day after it went out. The thiazolidinediones, which have been Actos and Avandia, and I haven't seen anybody write Avandia even though it was reapproved, are still have a place. And it's because they can be taken, once a day with or without food. They are now generic. They are cost effective. You can put them with a little bit of metformin and frequently achieve fairly decent results. They have always had a black box warning for congestive heart failure. Their nemesis is that if you have undiagnosed congestive heart failure, sometimes it will worsen it. And of course, the medications have to be stopped because they do tend to have someone, retain a little bit of fluids. But most of our folks can be handled with a little bit of mild diuretic. Their key element is that they enhance insulin sensitivity at the muscular and cellular level, meaning that they help open the doors and receptors to the cells, and they actually become a transport mechanism to push glucose into the cells so that you can burn it for energy. The other unique property that these have is that as they do that, they carry your lipids into your cells and they help you to burn your fats in your bloodstream more efficiently. So they will actually lower LDL. And when they do that, they lower CRP, which is that C-reactive protein, which is that inflammation and cardiac marker for the body. So if you have the patient that has some fibromyalgic problems, it may be a choice, because if you have them not hurting or not hurting as much, it's easier to motivate them to move. If they're feeling better, you can probably perhaps have them look at their lifestyle things such as their food choices with a fresher mind. And so we still have seen some great benefit. And there are ongoing trials to even have these medications with insulin, because it appears that they lower the amount of insulin that someone may require for glycemic control. So there's some benefit. Plus, they do act as a watchdog for that liver to decrease the amount of glucose that the liver has a propensity to continue to release even though you've eaten. So there are some true benefits to still consider Actos, at least, because it has some dosing options for patients who otherwise may not tolerate or may not be able to afford some of the other newer medication options. And now that it's generic, it's made it much more affordable. And I suspect that this slide may cause some distress for some folks, but that sulfonylureas have been removed from many of the formularies. And I know that we all have lots of patients who have been on sulfonylureas for years, but specifically the glucotrol and the glipizide have shown to not have met their cardiac endpoints, in that they help the body to use up beta cell function in a more rapid factor, which allows people to have, increase in either very high or severe low blood sugars if they don't eat. And there have been more MIs as a result of those rapid shift in glycemic excursions. So, glipizide is still one of the medications that's approved, that we use for our gestational diabetes folks. But Amaryl, which is the glyperamide, is the only approved sulfonylurea for someone over 60. And there are some huge clinical informations at the site that we have cited, which is from the Endocrinology Association in their resource guide, about why these medications are no longer recommended. What we are finding is that many of the big formulary companies who are medication folks, for example, CVS and Humana, they have actually removed them without prior authorization from their formularies. And patients are being asked to be seen and switched or swapped to another. If you choose to leave someone on a sulfonylurea, then Amaryl is the only one that they're stocking. So it's been an interesting change in philosophy, because, the sulfonylureas have been available to us for a long time, and they have been promoted because they've been generic for so long. And a lot of folks have been on them because we didn't want to put them on insulin, or, not everyone is appropriate for insulin due to sight or vision or costs or dexterity, or they have no safety mechanisms in their family life. So it's a change in philosophy. It actually came about a year ago. And as we have been traveling throughout the state, we have challenged a lot of folks to go read the clinical information that was available through the ACE website about the use of sulfonylureas, because it has changed some folks' practice. And I know that we still use it a little bit, but we have, over the course of the last 12 months, have, as patients have presented or as their pharmacies have requested, we have brought them in and made the switch. So it should perhaps offer up some conversation in your practices. There's been some really good discussions about the why behind it. And it's mostly about the extremes in glycemic excursion. And we probably all have a event that happened when the patient got their medicines and didn't eat and had an adverse event because of it. So, any comments, questions? Because we have a lot of travelers in Wyoming that pass through our state, even though we haven't used precarbose and acarbose in many, many years in a lot of situations, we still see it come through third world countries. We still see it used quite a bit in the South. And so as people come and visit, it doesn't mean that we won't see a few of those, but because it caused such horrible GI problems, and because it has to be taken as the last bite of almost like your dessert with each meal, you know, it fell out of favor many, many years ago, and it truly doesn't give much excellence in diabetes control. But it is still out there, and people are still prescribing it, so we still have it there. It was designed for those postprandial glucoses to help you digest your food better, so that perhaps folks would not need to go on to mealtime insulin. And we all know that if we can keep those postprandial excursions down to a minimum, maybe 50, 60 points, it also helps the inflammation index in the body, which is, of course, the culprit for cardiovascular and vascular disease. Insulins. Well, NPH and regular have been around since before I started practice. Original insulin came in the 1920s. And we're seeing a resurgence of both NPH and regular insulin because Lilly has made a version for Walmart that is generic. And people can get it for around $30 a vial. And with good education and good monitoring, we can achieve adequate glycemic control with few side effects or safety issues. And I don't know if anybody's priced the bottle of a bottle of Lantus lately, but it's about $300. And so if you can spend $30 for the patients who have not real good insurance or high deductibles or underinsured, we can still achieve good control with good education. Regular has come as a special order as U500, so I have 2 or 3 folks over the past few years that were on 700 to 1,000 units of insulin a day, and it can be put in an insulin pump. It takes a lot of education around that medicine, and generally we allow our endocrinology partners to manage those patients, and we are merely support. Apidra and Aspart, which is Novolog, and Lispro, which is Humalog, have now been around for years. We see them a lot for that mealtime or sick day coverage. We see it a lot in insulin pumps. Novolog and Aspart can be pretty much interchangeable, so that every July or January when we get formulary changes, we generally just substitute whichever one is covered, so it's for the patient's best benefit unless they have an allergy. Apidra is not quite the same. it has a quicker onset. So that patient who is going to eat has to really, truly be sitting down to eat before they want to give their bolus, because it has a slightly more rapid onset. It does hit those blood sugars a little bit harder, more quickly. And so to prevent low blood sugars while someone's cooking dinner, for an example, you really need to encourage that person to be sitting down, to be taking those first bites of food before they bolus. Very nicely, Humalog or Lispro now comes U200 in a smart pen, so that for that patient that's on 25 to 50 units at mealtime or other times during the day, it delivers half the volume. So if their dose is 25, they still dial to 25, but it only gives half that volume. So it's sight protecting, and it causes less irritation. And whatever they've done to stabilize it at U200, people tell us that it stings less when it's administered, which is a very positive thing. We're seeing a resurgence of premix insulins for that patient who can only afford one vial. That 70-30 premix gives good benefit with good education. So they truly understand how they're covering in the morning and how they're covering in the evening. And that person who eats breakfast at 8 and eats lunch at noon and eats dinner at 6, who has a very stable lifestyle, there are some amazing benefits to only having to take 2 shots a day and achieve really good and well titrated control without low blood sugars. Yes, it requires some education, and yes, it requires some work, but I think I see patients empowered to do great work with these medicines and get A1Cs at 7 without a lot of low blood sugars or a lot of high glycemic excursions, because it does give someone that mealtime benefit. And now we're going to change the culture of America. We have looked at basal insulins as that long-acting insulin, kind of like the long fairway on a golf course, for years. But the rest of the world has been calling these medications background insulins. And so if we think about what our pancreas does on a daily basis, it squirts a little bit of insulin out all day long. It's in the background of our mealtime boluses. So we added this, so as the literature is changing, we will stay proactive with the rest of the world. And we are also trying to call it background insulin, which takes a little work on our part. But it really keeps us in line with what's happening in the rest of the regions. And since most insulins are studied in Europe or in Asia many, many years before we get them, it keeps us in line. So we've all had Lantus insulin since about 1994. I know we all waited for it to come, hoping that it would really give us that once a day look to provide that background insulin so that the other oral medications would help maintain glycemic control. We know that it starts to work in 2 hours, it peaks in 4 to 6, but what we soon discovered is it really only lasts 12 to 24 hours. So we see it frequently given in split doses, and every patient is different. Every work environment that we do is different for them, but it's what works best for their life and their work cycle if they're working. But we find that many patients need a bridging dose either in the morning or at night, because it does tend to run out at 14 to 16 to 18 hours. But if we give them that nudge like we used to give, or like we do give for NPH, that they can do very, very well, and they balance more effectively with less insulin. And then this last summer, Bascalar came out, which is biosimilar, which is kind of another word, the new word for generic. Glargine, its action is the same as Lantus. It peaks and does everything the same, but it's Lilly's version of bringing a bioequivalent Lantus, but at a much less cost. And so where a vial of Lantus might be $300, and again, it depends on the pharmacy and depends on everything else, it's about a third of the cost. And I know that VA just put it on their formulary, and so have many of the others, because the cost savings to patients and to systems is so great. Trujeo came out 2 years ago. It is U300 Lantus, and it comes in a smart pen. It, much like U200 Humalog, this one delivers a third of the volume. So that patient who has large, is very insulin resistant, who needs large doses of insulin, and many of us have folks that are 100 units a day, it's truly site protective. People tell us it doesn't sting like regular Lantus. And whatever they've done to stabilize it at U300, it seems to truly last for 24 hours. So many pharmacy groups like CVS and other places have asked to change folks to Trujeo because they're not using as much insulin. People can take it once a day instead of twice a day, which of course is better for everyone. And people seem to take their medicine because it doesn't hurt, which is a positive for everything. And so we see more use of Trujeo today than we do Lantus. And it's actually came out cost effectively less, and it's covered better by most insurances, including VA and Indian Health Services. Levemir is still been a wonderful choice. Its action is much like Lantus, except that it does have a Category 1 rating or approval for pregnancy. And so we are seeing it as a choice for our type 1 patients or even our type 2 patients who become pregnant and controlling their diabetes during those times. And then most folks are left on it if they continue to need that. Again, it can be given once or twice a day, so it's infinitely titratable to how the patient responds. And it is in the same cost group as Lantus and Trujeo. And it is approved down to age 2. So with more and more pediatric patients out there, they have some more options other than just MPH. And then this last year came Tresiba, and it comes U100 for that patient who requires less than 25 units a day, or it comes U200. Its onset is slightly different. It's 2 to 4 hours. It does not have a peak. If you really look at patients on a continuous glucose monitor, it just comes to steady state, and then it seems to continue, and it does not have the wax and waning properties as some of the other insulins. So it can actually last 24 to 42 hours. And it just received approval down to age 1. So that small dosing patient may benefit from once a day background insulin. And it's covered now because of its efficacy and because of the cost, and it was brought out at a very reasonable price. For true consideration for a true background insulin. Some of us remember the old Ultralente, and we were all concerned about delayed low blood sugars, and it hasn't and doesn't appear to have that same issues. It really does seem to be more stable. And as a result, if somebody forgets to take their morning dose, as long as there's more than 8 hours before their next dose, they can actually take it without fear of stacking their medications. So for real life world, where folks frequently work rotating shifts or life actually gets in the way, there are some safety mechanisms built into this medication that still allow you to take your medication even if you've forgotten, or it helps with dosing for patients who are going to have some sort of procedure and you want them just to hold their medication for that morning while they are NPO, maybe for some test. They could still take their medication at noon and not have to worry about stacking their insulin. And that's a huge improvement over any of the insulins that we've previously had that were truly once a day. And then to make our lives even more complicated, there are many, many patients that have been on liraglutide, which is Victoza, who do need a nudge of basal insulin. And so Exultfi has been built, and it had 2 extra years of clinical trials to deliver not only the Victoza that someone is getting, but to also give them the nudge of background insulin, the Tresiba. And it can start at as little as 8 units a day, which is about what the starting dose of Victoza is, that 0.6. If you were to go to 25 units a day, it would give you the 25 units of insulin and the 1.2 of Victoza, and up to 50 units a day. And if someone requires more than 50 units a day of insulin, we really need to be looking at what their needs are, and do they just need their Victoza, and do they need a bigger dose, or what dosing adjustments, or maybe perhaps the Victoza's not really working and not controlling those postprandial and weight loss issues. So these patients were studied at great length with a tremendous amount of lifestyle intervention. And while we've kind of been watching these studies come through, again, we'll be selecting our patients very carefully, and they have to be well motivated. And the folks that we have seen, and they're doing very, very well. And most of them only need that nudge of insulin. And some of them are willing to still take the 2 shots, Tresiba by itself and their Victoza by itself. I haven't personally seen the cost of the new combo medicine, but I do know that it's covered by Novo with some coupons if they have commercial insurance, but not by Medicare. And I haven't seen it, and I'm probably sure we won't see it in some of the other very restrictive medication policies yet. Any questions before we move on? This is a lot of information. Usually this is a whole class all by itself. And while this is a review for many folks, some of the information is truly new, and it's really nice to have this review. But I'll move forward unless somebody has a question.
Yeah, go ahead if you do have a question, to put it in the chat box for Diane. And Diane, there is a comment. I don't know if it's exactly a question. I don't know if you can see that.
Tresiba after opening is good for 56 days. Yes, that was one of the other things that they have done, because most insulin pens, let's just take Novolog as an example, they're only good for 28 days after they're opened. Levemir is good for 42 days. They have stabilized Tresiba for 56 days, which you're not throwing out vials, you're not throwing out pens. That can become an economic factor for people who are on smaller doses that perhaps will reduce their insulin costs because they're only buying insulin maybe every other month instead of every month. And that is a good question. That is a good point. The next slide simply was provided again to us by the American Academy of Endocrinology. People are afraid to start insulin, especially if someone's on large doses of oral medications. This was presented to us to help give folks a guide of what medicines might you think about stopping if someone needs insulin. Maybe they just need that background or basal insulin. What happens when we need to intensify and give them that mealtime or sick day protocol? And we're seeing more of that, especially with our oncology patients. This was provided as a tool for us to think outside of the box, because a lot of providers aren't as comfortable as maybe some of our DSME sites or some of our endocrinology sites, we have a lot of freestanding nurse practitioners and PAs who need some guidance on how to start insulin and stop some of the oral medications or wean those medications. This was provided to give us a tool. And in that ACE guideline, in their resource toolkit, there's even some more great information to think about as folks move forward in patient treatment. Those of us who do it every day, this is still my friend when you have to go talk to a provider and say, how would you like us to do this? Because it gives us a place to start. And some of it is A1C founded. You know, if you've got someone with an A1C that's 13, we may put that person on insulin for a short period of time while we get the oral medications up to therapeutic use and the therapeutic level, and then wean that patient back and hopefully maybe even take them off. But at 13, you know, those red blood cells are coated and that insulin resistance is extremely elevated. The orals can take much longer to work, but if we give someone even a small dose of basal insulin, they will begin to work quicker and more effectively. And we don't want someone to have their heart attack or their stroke or some infection, you know, like pneumonia or a raging UTI or something while their blood sugars are so elevated. So a lot of that is about prevention of further complications. And some of those, you know, the cardiovascular ones, that long-term effect. So we're seeing insulin started sooner. We're seeing it started when, you know, the A1Cs are generally maybe perhaps greater than 9, certainly 10, while oral medications are coming to that level. So this was a tool that we wanted to share that's become very helpful as we think through the process of starting that person on insulin, besides their education component. I'm not going to make you guys do a quiz, but when we do nursing students, we know that there are so many medicines that sound alike. And even though a medication says that they may not cause low blood sugars, we all know that unless we as patients, we as clients, we as family members, if you don't eat and if you overexercise, anyone can be at risk of low blood sugar. And a lot of medicines now come with metformin at their core. Actos plus Met, Janumet, Combigliza. We have to remember that they may be out of 2 medicines if we have to stop them because they're not eating, if we have to stop them for a diet-related procedure, and we may, or because of renal impairment, that you might be stopping the metformin, but we also might be stopping that Januvia, and do we need to reorder the Januvia as a sole pill? So that we don't forget to do that. And we want patients to do well. So it's just a point of consideration. Given the new blood pressure guidelines as one of the metrics, especially here in Wyoming for the new MIPS guidelines for how people may be reimbursed and the new metrics for NCQA and all the alphabet soup that we now have for reimbursements. This guideline, even though it was originally written a couple of years ago, it still pertains to thinking about how we treat hypertension. And since hypertension and diabetes and CHF are the 3 main components for primary care, we brought this back in just so that, again, that we think about what's happening for patients. Self-management is, of course, is still always the piece. And the new guidelines say that if you're treating someone with 2 or more medications, they should be referred for nutrition and that DASH diet, which is that dietary approach to stop hypertension diet. And we have to document that we've done that. And of course, the emotional stress, if somebody's not able to take care of themselves, if they've got a lot going on, we need to remember the broader picture. And so there, you know, ACEs and ARBs have been around forever. Most folks start with a little, some sort of diuretic, and it moves through the algorithm depending on what we see in our patient. And just like our diabetes medications, there are lots of different options for blood pressure medications because not everyone tolerates everything. So, but this is a guideline. It's just a thought and considerations for how to add medications to achieve better glycemic control. And since that new guideline says, what do you do with a blood pressure of 140/90, and that we're supposed to take it again, document it, and if it continues to be the 140/90, we need to be having those conversations or need to begin to treat age and risk appropriately, because some of us are over 60, so it's not as tight as it used to be. It begins to give us thoughts on how to look at a patient across the continuum. And, you know, there are lots of different medications and lots of different dosings, but there are 5 major classes, and I've included them for you, and we all understand about diuretics, so I am going to move on because I see we're getting low on time. One of the things that, and I'm going to skip the ACEs and ARBs because we all use them, one of the things we have to consider for the patients with diabetes is the beta blocker, especially if the patient has had a recent MI or is having cardiovascular issues. It is, of course, the best drug. It's the one that's recommended. But if you have a patient who has had really good glycemic control, they have their cardiovascular event, they're recuperating really, really well, but 4 to 6, maybe 8 or even 12 weeks later, now their blood sugars aren't good, beta blockers go through the beta pathway, which is where insulin production happens. It can actually suppress it. It can make them not lose their hypoglycemia awareness. So if people come in and complaining, I haven't done anything different and now my blood sugars are awful, or I've had more low blood sugars when they've been started on their beta blocker, we have to pay attention. It needs to be one of our red flag triggers that, especially for that first 3 to 6 months, we need to watch that patient more closely because they're more at risk for complications, and especially hypoglycemia unawareness. So it's just a little FYI. It's one of the things that sometimes we forget, and if we can be proactive and we at least warn the patient that their blood sugars could change or that they could experience more lows, then we can help them prevent any long-term problems. Any other questions or concerns as I see that our time is waning? Again, I appreciate being able to do this in an hour at lunch. This is a class that sometimes we will take much, much longer and have, of course, an active conversation around. And so for us to be able to even do this in this manner and share this is our pleasure. Thank you.
Diane, thank you so much. We do have a couple of minutes. We'll see if any other questions come up. We will go ahead and post the evaluation. Again, appreciate everyone, next few seconds or so to go ahead and fill that out for us. That'd be fantastic. And Diane, this content was just fabulous. It's been a while since I've been in the hospital or worked on the floor, and so there was lots for me to catch up on and learn, and I really appreciated it.
Well, this is one of 6 modules actually that we provide. We do Diabetes Basics, which is a good, just a review of diabetes. So if you have nurses or MAs or community health workers that are working in your programs, we actually come and provide that again for free because it's good for everybody to be on the same page. Module 2 is all about hypertension because we even give people the Million Hearts toolkits if they need to do a CQI project. Module 3 is this medication module that we just completed. Module 4 is actually a nutrition module. And for some of our DSME sites, we actually have a Module 5, which is advanced nutrition to help them with doing counseling. And the newest module, which does not have CME credit yet, is all about the new diabetes prevention programs, which we're moving forward with and actually beginning to do training for Wyoming in August. And so you'll hear a lot about the new diabetes prevention programs coming, and we're ready to move forward to 2018.
Perfect, perfect. Well, we may just be able to have you back as hosted by the PCA because some of those topics I think are of importance and of interest to our network. Since we are at the top of the hour, we'll leave the presentation open so you can finish your evaluations. But at this time, we're going to go ahead and shut off on our end. Do appreciate everyone joining us today. Diane, again, thank you for your time, your expertise, and it was very much appreciated.
Oh, you're so more than welcome. And if anybody needs anything, they can contact us.
Thank you. Oh, yes, we will post the slides, absolutely. We'll put them on our website. That was a question that came in just now.